Hi everybody, welcome to Dr Manny's YouTube Learn Shops, and in this Learn Shop we review the management of generic disorders requiring intensive care. This is part 2. Now the learning objectives are to review the management required for the selected medical conditions in the ICU that we looked at previously, and the recommended nursing care for those same medical conditions. Now the common medical conditions, just to reiterate, were respiratory failure, cardiac failure, shock, sepsis, diabetic ketoacidosis, stroke, and respiratory distress syndrome. Respiratory failure, remember, is a medical condition in which your blood doesn't have enough oxygen, hypoxia or hypoxemia, or has too much carbon dioxide, hypercapnia or hypercarbia. Sometimes, as we mentioned previously, you can have both problems occurring simultaneously. Pneumonia, let's reflect. This is right-sided middle lobe pneumonia. Congestive heart failure, pulmonary edema, foreign body airway obstruction, which results in airway obstruction and causes atelectasis, which this one is demonstrating. Atelectasis, acute respiratory distress syndrome, trauma, chronic obstructive airways disease, scoliosis, which could be kyphoscoliosis, cystic fibrosis, tuberculosis. Now the medical management, the important aspects are to identify and treat the cause. And remember, life support. If you want to reflect back on what life support is, go to the Dr Manny Learn shops on life support, both adult and paediatric. But remember A, B, C, which is now CAB. Compressions, airway breathing. Maintain and protect the airway. Provide oxygen therapy if required. Caution with chronic obstructive pulmonary disease. Provide hydration, bronchodilators, mucolytics. Arterial blood gas analysis is always helpful. Intubation could be considered, and invasive or non-invasive mechanical ventilation. The nursing management essentially requires competent nurses who adhere to the doctor's orders. And the orders may relate to medications such as antibiotics, bronchodilators, and diuretics to offload fluid. You monitor the patient, such as vital signs, especially the respiratory status, arterial blood gas analysis, and the response to therapies. It's important to report and document all changes, whether positive or negative. And always provide basic care such as mouth, eye, skin, and pressure ulcer prevention therapies. In cardiac failure, reflecting, it's a chronic progressive condition that affects the pumping of the myocardium. It's also known as congestive heart failure, and essentially the heart muscle just isn't pumping well enough and doesn't meet metabolic requirements. Left ventricular cardiac failure, remembering, it's failure of the left ventricle, which essentially results in pulmonary edema, pleural effusions, cardiomegaly. Right ventricular cardiac failure is failure of the right ventricle to pump effectively blood to the pulmonary circulation, and in doing so, there are peripheral circulation consequences, whether it's to do with hepatomegaly, splenomegaly, peripheral edema. Congestive heart failure is a combination of both, also known as biventricular failure. Now, the medical management of cardiac failure is also to remember your ABCs, airway, breathing, circulation, now known as circulation, airway, and breathing, which means chest compressions occur first if required. You can increase oxygen therapy, you can increase myocardial contractility with certain vasopressor agents, such as epinephrine, dopamine, dobutamine, norepinephrine, and so on. If you're interested in the pharmacological aspects, go to the Dr Manny Learn shops on pharmacology. Also, the medical management tries to decrease myocardial oxygen demands and decrease circulatory preload and afterload to make pumping in the heart more effective, and also to manage dysrhythmias such as premature ventricular complexes, ventricular tachycardia, and any other dysrhythmias that may occur. The nursing management again requires competent nurses who adhere to the doctor's orders. And your role is to monitor the patient's vital signs, especially the respiratory status again, and heart rate, blood pressure, capillary refill time. It's important to do arterial blood gas analysis and monitor the response to therapies and to document both positive and negative changes. And always providing basic mouth, eye, skin, and pressure ulcer prevention therapy. Shock, reiterating, is a major medical emergency and common after any serious injury, such as a motor vehicle accident, somewhere where there's trauma. It's a critical condition that's brought on by a sudden drop in blood flow through the body. The circulatory system fails to maintain adequate blood flow and the delivery of oxygen and nutrients to vital organs such as the brain and the heart. Types of shocks we said were hypovolemic, distributive, cardiogenic, and obstructive. Hypovolemic, loss of volume. Distributive can be neurogenic, which means head or spinal injury. Can also be allergic or anaphylactic. Can also be septic. Cardiogenic shock, essentially the heart's not working effectively. This can be related to myocardial ischemia, infarction, cardiac dysrhythmias such as premature ventricular complexes or ventricular tachycardia, with or without a pulse. Obstructive shock can include pericardial tamponade or effusion, pneumothorax, which is typically going to be tension, obstructive, such as pulmonary embolism, obstructing blood flow through the right heart circulation. The medical management, A, B, C, CAB. Airway breathing circulation, circulation airway breathing. With hypovolemic shock, replace volume. Distributive shock, treat the cause. The cause has to be treated first, but you can maintain pressures with vasopressors, such as epinephrine, norepinephrine, dopamine, noradrenaline, and you can give volume. Cardiogenic, decreasing preload, afterload, and myocardial oxygen demands to try and increase cardiac output and control dysrhythmias. Obstructive, treat the cause. The nursing management again requires competent nurses that adhere to doctor's orders. Monitor all vital signs, temperature, pulse, respirations, blood pressure, pulse oximetry, and even pain as the 6 vital signs. And monitor the response to therapies. And always document positive and both negative changes, which must be escalated to the physician or your immediate supervisor. Basic care always includes mouth, eye, skin, and pressure ulcer prevention. Stroke, we said in lay terminology, was a brain attack. And this occurs when blood flow to an area of the brain is interrupted, and this happens when the brain cells are deprived of oxygen and begin to die. You can have 2 types of stroke, ischemic and hemorrhagic. The medical management, if required, airway breathing circulation or circulation airway breathing. Control the blood pressure, no hypertension. Control the body temperature, no hypothermia. You don't want to increase the intracranial pressure, so this is controlled. Position the patient's head of bed at between 30 and 45 degrees. Hypertonic solutions can offload fluid. Maintain normal blood glucose. You don't want the patient to be hypoglycemic. Reverse any coagulopathies to stop any further bleeding, if that's the situation, and the patient may need to be intubated and ventilated with intermittent positive pressure ventilation, IPPV. The nursing management requires competent nurses who adhere to doctor's orders, who monitor the vital signs, the Glasgow Coma Scale, and response to therapies, and to document the response to those therapies. and always maintain basic care such as mouth, eye, skin, and pressure ulcer prevention care. Just to reiterate, the Glasgow Coma Scale is only one tool to assess neurological status. When we look at diabetic ketoacidosis, remembering it's a serious complication of diabetes mellitus type 1 that occurs when your body produces high levels of blood acids called ketones. Ketones, this is a condition where your body can't produce enough insulin. And without insulin, the body breaks down fat, and this provides increased level of ketones and acids in the body, creating an acidemia. The medical management, again, is ABC, circulation, airway, breathing, and the ultimate objective is to reverse the dehydration. So IV normal saline and then half normal saline can be given according to doctor's orders. Insulin therapy is provided to lower the high serum blood glucose levels. Electrolytes, which will be deranged, must be restored to normal because these have been changed because of dehydration, and acid-base derangements also have to be corrected. Metabolic acidosis. Treat the illness or infection that may be contributing, otherwise things won't change. The medical management of diabetic ketoacidosis can be put into three categories: dehydration, hyperkalemia, and acidemia or acidosis. Insulin therapy is the primary treatment. However, remember, before giving insulin therapy, the patient has to be normokalemic. Otherwise, this can create further problems to do with electrolytes. When it comes to dehydration, you correct the fluid deficit according to the medical orders. What you see in front of you is just one example. Severe, replace 1 to 2 litres per hour. Mild and moderate, 500 to 250 mils over a 4-hour period. Then review. You always monitor the serum glucose, and when it gets to about 12 to 14 millimoles per litre, then the patient is considered to be potentially stable. It depends on what caused the problem as well. When it comes to hyperkalemia, the potassium, if it's less than 3.3, then no insulin is given until the potassium is greater than 3.3, because the insulin will drop the potassium further. So the insulin is only given when the potassium is in the normal range. If the potassium is greater than 3.3, then KCl, potassium chloride, can be given. And typically it's about 20 to 30 milliequivalents in IV fluids. The goal is to maintain the potassium between normal levels of about 4 to 5 millimoles per litre. But again, it depends on your protocols and your physician orders. This is just one example of the management of diabetic ketoacidosis. So the nursing management, always we need competent nurses who maintain strict adherence to doctor's orders. You monitor the patient vital signs half hourly to hourly or according to your unit policy. Serial serum glucose is taken every 4 hours. Acute checks or quick analysis of blood glucose, finger pricks, every hour. Serum and urine ketones every 4 hours. Serial electrolytes every 4 hours. But again, it depends on your unit policy. You report and document changes in relation to response to therapies, and you are always providing mouth, eye, and skin pressure ulcer prevention care. The that we want to review is ARDS, Acute Respiratory Distress Syndrome. And as we mentioned previously in Learn Shop 1, a progressive syndrome in critically ill patients. And what it essentially does is cause an acute lung injury, damaging the alveolar capillary interface, where gas is exchanged. This also increases pulmonary capillary leak, permeability, and alveolar fluid in the lung. And it's typified by non-cardiogenic pulmonary edema, which means it's not caused by the heart, respiratory distress, and refractory hypoxemia, which means it's very difficult to treat. It doesn't respond to oxygen. Now, the direct causes we said were pneumonia, gastric content aspiration causing a pneumonitis. Less common, pulmonary contusion, fat embolism, near drowning, whether it's fresh or salt water, inhalational injuries such as smoke, burns, or chemicals, and reperfusion injury post-lung transplantation. Indirect causes can be sepsis, any shock state causing hypoperfusion of the lung, cardiopulmonary bypass, drug overdose, acute pancreatitis, and multiple blood product transfusions. The clinical signs and symptoms we said were early, however it does depend on the cause of the ARDS. It can be restlessness, confusion, level of consciousness changes, fatigue, shortness of breath, hypotension, cough and fever typically associated with infection. The chest x-ray, as we mentioned previously, is usually normal. The patient is clinically ill, but the chest x-ray is clinically normal in less than 48 hours after the syndrome begins. When it's later or greater than 48 hours, the chest x-ray becomes sick. It looks sick, and the patient looks sicker. Laboured breathing, dyspnea, tachycardia, cyanosis, metabolic acidosis, pulmonary crackles. They have a decreased PaO2 and an increased PCO2, indicating hypoxemia and hypercarbia. The chest x-ray looks abnormal. The patient looks sick. They're typically already intubated and ventilated. Complications were hospital-acquired infections, ventilator-acquired events such as ventilator-acquired pneumonia, barotrauma such as pneumothorax, Bali, ventilator-acquired lung injury, deep vein thrombosis, pulmonary embolism, renal failure, sepsis, disseminated intravascular coagulation, coagulopathy, DICC, and pulmonary fibrosis as a result of scarring. The medical management depends on your organisation, but the general principles are supportive care. Treat the cause, ICU admission, oxygen therapy, tracheal intubation, mechanical ventilation, sometimes even vena-venous extracorporeal membrane oxygenation. Have a look at the Dr Manny Learn shop on VV ECMO. It's simple and it's informative. And supportive care is always important. Positioning strategies, sometimes proning, fluid, restrictions, nutrition, stress ulcer prevention. There are lots of different management regimes, and your organisation will have its own depending on the intensivist. But essentially, it's supportive management. The nursing management requires competent ICU nurses, strict adherence to physician orders, and close monitoring of the patient's vital signs, oxygenation via arterial blood gases, intermittent positive pressure ventilation, and strategies such as PEEP, positive end expiratory pressure. If you're not familiar with ventilation, look at the Dr Manny Learn shops on mechanical ventilation, which are non-invasive and invasive. It's always important, as we mentioned previously, report and document changes in relation to response to therapies and provide basic care, mouth, eye, skin, pressure ulcer prevention, suctioning nebulization, and physical therapy. In summary, an ICU and an ICU nurse specialises in providing care for specific health conditions or injuries which include major trauma, severe burns, respiratory failure, after cardiothoracic surgery, organ transplants, complex spinal surgery, but the important thing is that care must be provided by you as a competent, caring nurse advocate with critical thinking skills. So let's review activity. Can you name two types of respiratory failure? They are type 1 hypoxemic and type 2 hypercapnic or hypercarbic. Hypoxic is oxygen failure. Type 2 is ventilatory failure. Name the causes of respiratory failure following the diagram. Type 1 hypoxemic, pulmonary edema, pneumonia, acute lung injury, atelectasis, aspiration, pulmonary confusion, pneumonitis, pulmonary embolism, and many others. Hypercapnic or carbic, pump and load problems, CNS depression, brainstem injury, spinal cord injury, neuropathies, chronic obstructive pulmonary disease, asthma, cystic fibrosis, and bronchiectasis. Reflect on the signs and symptoms of heart failure, which I'm not going to do in any great detail. You can review them because they should be important to you. if you're looking after these sorts of patients. But again, essentially, sympathetic stimulation causes anxiety, pale, grey or cyanotic skin, confusion. What you'll see is Jvp elevation. The patient could be dyspneic, orthopneic, have crackles and wheezes when auscultating. They could be coughing up pink frothy sputum. They could be hypotensive. They could have ascites with dependent pitting edema. They could have abdominal pain. They will have weak, thready, rapid pulses. Oliguria will be an issue. They may have a third or fourth heart sound called an S3, S4 gallop as a result of heart failure. They may have had myocardial ischemia and a myocardial infarction. Their saturations will be very low. Name 4 generic types of shock, and these are hypovolemic, distributed, cardiogenic, and obstructive. Can you remember 4 early and 4 late signs and symptoms related to diabetic ketoacidosis? Images should give you some clue. So, feeling thirsty, polydipsia, urinating often, polyuria, high blood glucose levels, hypoglycemia, high ketone levels in the urine, ketonuria, feeling weak or constantly sleepy, they're fatigued, dry, flushed skin, they're dehydrated and dry, nausea and vomiting and pain in the abdomen, dyspnea and acetone, fruity smelling breath. Name 6 components of the BFAST acronym to determine stroke. They are balance, eyes, face, arm, speech, and remember the window to activate the acute medical response, time. To get them now to a centre where maybe therapy can be initiated to dissolve a clot or control bleeding. Name 4 clinical signs, early stages of ARDS. They are restlessness, confusion, level of consciousness changes, fever, cough if septic, hypotension, shortness of breath and fatigue. The chest x-ray isn't a clinical sign. It could be, essentially, but it's usually normal. 4 clinical signs of later stages of ARDS, difficult breathing. Work of breathing is marked. They've got use of accessory muscles. Dyspnea, tachycardia, cyanosis, frothy sputum, metabolic acidosis, pulmonary crackles on auscultation, and they've got decreased PaO2 and increased PaCO2, indicating PaO2 hypoxemia, which is refractory, and increased PaCO2, which is now telling you they can't eliminate carbon dioxide. The chest x-ray, absolutely abnormal. Okay, thank you. That's the end of this Learn Shop. And check out other Dr. Manny Learn Shops on YouTube. And please, if you found this of any benefit to you, recommend it to your colleagues and subscribe. See you for now. See you in other Learn Shops.